And now it's time for Through the Eyes of Dr. Mittleman, brought to you by Mittleman Eye, with 2 locations, West Palm Beach and Jupiter. And now here are your hosts, Jill Schweitzer and Dr. David Mittleman.
Good morning, Dr. Mittleman. What a treat to be back with you here on our Saturday morning Cozy Chats.
It's just as nice for me, Jill. I'm very happy to be here. I look forward to doing this all week long.
I do too. I'm learning so much, not only about your travels and the really weird and exciting and adventurous things that you've eaten, places you've been, music that you've experienced all over the world. But let's talk about your Mittleman Eye practice today. I know, something crazy, but It's interesting. We spoke before and you said one of the questions you get all the time when people come in because maybe they think they just need glasses, like a new prescription on their glasses, is they say, well, why do I have to have this test? And why do I have to have that test? And you're very thorough. One of our listeners said it was the most thorough examination they had ever had before they got their cataract surgery. So why the test?
So ophthalmology today is very different than it was even when I was in residency. Certainly 30 years ago in residency, we had plenty of tests. But originally, an ophthalmologist would be in a 20-foot long room with a fixed chart at the end of the room, and you could memorize the letters. He had a handheld little instrument that he would look into your eyes with, and that was it. And people lost their vision, and we didn't know why. People had infections that we couldn't resolve, and we didn't know why. But many times now, we do know why. We can prevent disease, and that's because we have all of these machines. And much like other things, I tell people who are not getting better, I said, are you using your eye drops? And they say, well, no. I said, I prescribed them last week. I told you twice a day for a week. And they said, well, I forgot. I said, well, the bottle that has the drops, it's actually doing really well. It's cured because it has the drops in it. But you have to use your drops. You have to use your equipment. Otherwise, you don't know what it's going to tell you. And so I'm thinking about a patient I just saw a couple of days ago who had decreased vision. And I didn't know why she had decreased vision. And the exam looked normal. And so there are a lot of different tests that you can do. And so the first test that we do on almost everybody when they come in is something called an OPD. It's an autorefractor and a topographer. So let's talk about what that does and why we do it. So the autorefract measures your eyes in a way that we can find out exactly what your prescription should be. In the old days, we had something called a retinoscope. It was a straight beam of light, and it was sort of like voodoo medicine. Mm-hmm. You would streak it. It was actually called streaking up and down. You take this light up and down, whether it's vertical or horizontal or diagonal, and you would try to assess how thick the beam was, how fast it moved, and that would give you an idea of what the person's prescription for their eyeglasses should be. The OPD tells you exactly what the prescription should be. Now, your brain, my brain, everyone's brain, doesn't necessarily want what it needs. I don't eat always what I should eat. I don't always do what I should do, but it tells you what you should have. And then it's a great starting point for the technician and the doctor and the optometrist to fine-tune it to what your brain needs. But it's a great starting point that you wouldn't ordinarily have. One of the other things this OPT machine does is it says what the curvature of your cornea is. So the cornea is the clear part of the eye that covers everything. The retina doctors will say it's just a dust cover, but it really is the largest refracting surface, meaning it is the biggest surface that focuses light on the retina so you can see. It also has more nerves than anywhere else in the body because evolutionarily, I guess it was determined by reproduction that this is the most important part of the body. This is what you use to see with so you can find food, so you can avoid danger, so you can find a partner. And the topographer will find irregularities in your cornea that I can't see. So there are some diseases are certainly very easy to see, but there are some that are very subtle that the human eye can't pick up. It will pick up early keratoconus, which is a disease often in younger men. It will pick up irregularities from a pterygium, which are very common in here, growths across the cover of the eye, and will tell you why somebody doesn't see as well as they should. It's a very quick test, but very important.
So is it just basically you're looking at something? I mean, what does the test involve for the patient?
Like most of our tests, they're either computer games or you just stick your head in a machine. And what I usually tell patients when they're getting measured for cataract surgery is you're going to be in many machines, and you're going to look at the house, you're going to look at the car, you're going to look at the boat, you're going to look at the goat. And then I usually look at them and say, no, we don't have farm animals in our machine. Usually gets a laugh. But you just sit there and it takes a picture.
Okay.
Of various sorts.
So what other tests might a patient, do they definitely get that, the OPD, if they're having issue with their vision?
Well, everybody gets an OPD at the start of the exam because if they want a prescription for glasses, it tells us where to go.
Okay.
And it's a very simple test. The topography comes along with it, doesn't take any extra time. We don't bill for it. It's just something that we do because I think it's good medicine. A lot of things we don't charge for, but they're good medicine. And you always take care of patients first. That's one of our mottos, patients first. And I don't really care what the insurance pays for and what it doesn't. I want the information to diagnose the patient and treat the patient.
So what's another test that might be?
So one of the other tests, which was developed by a physician in Miami, is called an OCT, an ocular computed tomogram. It's a very expensive machine. They range anywhere from $65,000 to $250,000. And it does three things. It's a 3-in-1 test. It will measure your retina, the macula. It will measure your optic nerve, and it will measure the front of the eye, where the drain of the eye is. And so it's a fascinating machine. It gets better and better. I have 3 brand new ones. They keep on coming up with new ones that are better every couple of years, and despite the cost and the low reimbursement, they are crucial for determining what's causing a patient's problem. So the first thing we can do with this is it will look at the macula. The macula is the center of the eye. You can also look at other parts around the center of the eye, but most people are familiar with macular degeneration, which is a type of aging change in the back of the eye which can rob your central vision. So it will look at this and tell me different issues that are going on with the macula. It will determine whether there are wrinkles on the retina, whether there's poor blood flow to the retina, and the retina is dying of ischemia or a lack of oxygen. But it reminds me of this patient that I saw just a few days ago. She had an OPD. She had decreased vision in one eye, and I didn't know why, so I looked at her topography and it was normal. So I sent her for this OCT of the macula. You have to choose which one. Insurance will only pay for one each visit. And some doctors make patients come back for multiple visits to do multiple tests. I will just do them all if I need them all and only bill for one. And she came back, and sure enough, she had wet macular degeneration. This was not something visible to the naked eye. When I was in residency, you were told if there's a little green sheen, that means there might be blood. Of course, that's not true. It's a potential indicator. The only way to tell if you had macular degeneration that was wet, unless you saw blood there, was to put an IV in, put dye in your arm, take pictures for 20 minutes, rapid cycle, and see how the blood was leaking. Of course, there are people who are allergic to the dye, who had reactions to the dye. There are people like myself who hate needles. And so this test picked up a very thin layer, a couple of microns thick, 1,000th of a millimeter, and said there's fluid under the retina, even though it's not visible to the naked eye. And I saved this woman a bunch of other tests with needles, off to the retina doctor for injections that will return her vision back to the way it was, with a simple 30-second test.
Again, we need to get to the eye doctor, kids. Dr. Mittleman. And not just any eye doctor. I'm loving the way that you approach this. Like, you're going to get to the bottom of this no matter what. And I love that.
So sometimes, even with all these tests, I'll look at a patient and say, I don't know. They teach you in medical school, never, never, never tell a patient, I don't know. They want patients to think of you as a god. And that's not true. We're people. We don't have every answer. And so I do say I don't know, but I always follow it up, but we're going to find out. And I think that's entirely acceptable. If a patient thinks I know everything, they're unfortunately sadly mistaken. I know a lot. I like to think I'm very good at what I do with a broad knowledge base, but I can't know everything. And so on this OCT machine, I said it does three things. It also will measure your optic nerve, which is adjacent to the macula. It sends a signal from your eye to the brain. There are a lot of things it will do to measure the optic nerve, but one of the things it will do is measure how big the hole in the optic nerve is. I like to tell patients that the optic nerve looks like a donut, a Cheerio, a bagel, a Lifesaver. As we found out from these other shows, I love my food.
You're speaking my language right now.
And so I think of everything in terms of food because I'm always hungry. And so when you have glaucoma, the hole starts out small and gets bigger and bigger and bigger. And once you lose about 80% of your optic nerve, you start to lose peripheral vision. And even then, patients don't realize it. But there are some people who are just born with big optic nerves, with big holes in the nerves. And there are people who have come to my office who have been treated for glaucoma for years, unnecessarily. And I look at their optic nerves, and sure enough, the hole is big. 30 years ago, you would say, you have glaucoma. But we can do this test, which compares what your hole and what your nerve rim looks like compared to age, sex, race, match normals. And it will say, no, this is not glaucoma. This is just somebody with a big nerve and a big hole. You don't need treatment. It's an amazing technology.
Wow.
The machine will also measure the angle between your cornea and your iris. So here we have the limitations of radio. People don't understand what the angle in the eye is. It's where the fluid drains from, and that angle gets narrow. And if it gets too narrow, it can close. Your eye pressure can go up to 70 from a normal 18 within a matter of hours, and you can go blind in 24 to 36 hours unless treated. People would come in with narrow angles, and I would say, your angle is narrow. We need to do a little laser to let the fluid flow properly so it doesn't build up. And people would look at me and say, I have no problem. I see fine. I don't have any pain. Why do I need this? And many people would trust you. But this actually takes a beautiful picture of the angle of the eye, and I can put up a piece of paper with what a normal angle looks like, and immediately the light bulb goes off and the patient says, that's me? There's no room there. That's why we need to do a laser hole.
Wow.
So these are not just for diagnosis, but they're also for education. Because if the patient understands what you're doing, there's more of a buy-in, and they're more likely to comply with treatment.
Sure. So what other, are there specific tests that you do automatically, and then there are those that you do where you see something, you say, well, we need to do further tests, which...
So we do the OPD on everybody.
Okay.
We have what I call a poor man's OCT when we do cataract surgery, which gives me a rough image, and if it's not normal, then I do the full-blown OCT. But we have tests, for instance, an endothelial cell counter. So the endothelial cells are cells on the back surface of your cornea, this dust cover of the eye. You are born with all the cells you're going to have. It's called neuroectoderm. That's the cell line that it comes from. They don't reproduce. So if you cut yourself, your skin grows back. If your bone breaks, once you set it, the bone grows back. Your endothelial cells don't grow back. That's it. We're working on ways to grow them in a petri dish, but it doesn't really work so far. So there are some people who have a genetic trait where your cells start to die prematurely over the age of 50. And if you lose enough cells, these cells are responsible for sucking the fluid out of the cornea, keeping it clear so that you can see. Think about a window that's dirty. There is no easy way to clean it. You can do a transplant and replace these cells, but they don't grow. And so you can see when the cells have died. And this endothelial cell counter will count the cells very precisely from year to year, so you can tell the patient, you'll be fine. At 137, you might need a corneal transplant, or if we do cataract surgery, your cornea is likely to fail. We can't tell the function of the cells. So there are some people who have a limited number of cells, but they function really well, and there are people that have a lot of cells and they don't function well. So it's not a foolproof test, but it shows the patient once again what their cornea looks like and how it's different than an average person. I hate to say normal, average is a better way to say it, and how they're progressing. It's a great tool for me to determine what's going on, how they're changing from year to year. One of the things I love about ophthalmology is I do see the same patients from year to year. We do build a relationship, as opposed to the general surgeons that we talked about in another episode that are not nice. They see it, they fix it, they're done. I didn't like that. I like to know my patients. And an endothelial cell counter really helps you to do that.
So is that one you would do once a year?
We do it once a year on people who have this issue. It also works in people with trauma. You can lose endothelial cells from trauma. There are some congenital conditions that will do it. If you have inflammatory conditions, that will make you lose your cells. So there are all different kinds of diseases. The ophthalmology Bible is called Duane's. Last time I had a physical copy of it, it was 7 volumes long, and each volume was anywhere from 1,500 to 2,000 pages. It's now, of course, online. It went to a CD disc, but even that doesn't exist anymore. But at one point, I knew everything in those 7 volumes.
Oh, my God.
There are things now I look at and I say, you're going on the Mittleman rocket. I know what it is, but I don't keep up enough with certain retinal diseases because it's not what I do. But you have to be able to recognize these things and know where to send it, which doctor will be able to fix this.
Yeah. I have a crazy question. My mother had glaucoma, and she would take drops. This is many years ago. And her lashes got so long and beautiful. Is this making sense to you?
So we still do this.
Okay.
So way back when, the only treatment for glaucoma was something called pilocarpine. It was a 4-time-a-day treatment. It gave you a headache and made your pupils small. It caused cataracts. It made surgery difficult. People don't remember 4 times a day. It was an awful drop. Breakthrough. We get timolol, which is a beta blocker, which people still use today, and it was once or twice a day, and it didn't have all these horrible side effects. It had some. You couldn't use it in patients with asthma. You couldn't use it in patients with congestive heart failure. It sometimes slowed your heart rate. And although this is a family radio station, it could also make Mr. Happy not happy. And so men often didn't want to take this, but it worked, and it was much easier and much more efficacious. Along comes the prostaglandin analogs, and that's what you're talking about. The first one on the market was Zalatan, and then there was Lumigan, and then there's Travatan and Zioptin. There's actually just a new one just approved in a gel form that's preservative-free because we've come to learn that preservatives are bad for the eye. So the prostaglandin analogs do some very interesting things. They can make blue eyes brown permanently. We don't often talk about people with brown eyes like myself, but it can actually make brown eyes darker permanently. Will also make lashes thicker and more lustrous. And when I say that to men, they look at me like I'm crazy and say, so? Women love it. And in fact, it's been repurposed as Latisse. It also can do some other things. So Brooke Shields, hopefully I'm not speaking out of turn, used Latisse, and she was a spokesperson for Latisse. But the drop will also cause loss of periorbital fat. So people think, I don't want fat. But you do want fat in some parts of your body. Otherwise, you look like skin and bones. And there is fat around your eyeball. And if you lose it, it makes your eye look sunken in. And Brooke was losing some periorbital fat and didn't like the look. You can't replace your periorbital fat. It doesn't grow back. So there are side effects to all these medicines, but Lumigan and Zalatan and Travatan worked better than any other drop on the market. They are still one of our first-line drops because even though I say there are these side effects, they're well tolerated. They work dramatically well. One of the newest innovations, you can actually inject a pellet with these medicines in the eye so you don't have to take the drops.
Wow. I was just curious about that. I did do the thing for the lashes for a while, even though my eyes are blue, and I was like, but vain as the day is long I am. I wanted those long, lustrous lashes, but then I was like, I was too worried about side effects. So on we go. More tests.
So we have 2 fundus cameras. A fundus camera takes pictures of the back of the eye. So we have one that will take very detailed pictures of your optic nerve and your macula. We do have this OCT that will measure your optic nerve, but when I was in school, you had to draw the optic nerve. There was no machine to measure it. There was no camera. And I would spend hours drawing optic nerves, comparing them to what the attending saw and how the attending drew it. I became very good at drawing optic nerves. You can't draw an optic nerve on a computer screen. It just doesn't work, at least in the average ophthalmologist's hands. So we have these cameras that will take pictures of the nerve. They'll take pictures of your macula, of the macular degeneration. They'll take pictures of freckles in the back of the eye, of tumors in the back of the eye, of pieces of cholesterol in the blood vessels. And so you can go back and look at these pictures as you're examining the patient and say, it's exactly the same, or it's worse. It's a great way for the doctor to tell what the progression is, but once again, to show the patient what's happening in their eyes. Radio, yes, but a picture paints 1,000 words. So you can talk to a patient for hours telling them something. You show them a picture of what they have, and they go, oh, well, that's not good, or wow, it does look exactly the same. I'm going to be good for another year. It's very satisfying to see the light bulb go off in the patient's eyes and for them to understand what you're saying.
Yeah, no, I like that. I'm a visual learner myself, so that would be really helpful. So what else you got there, Dr. Mittleman? You're full of tests over there.
So there's one other test that we do all the time, and then we won't talk about some of the other machines that we don't use that much, but this is a machine that's roundly hated by almost every patient. It's called a visual field machine. It tests your peripheral vision, and it's an automated machine that will shine white lights at you of different intensities and different sizes. And like a video game, you have to press a button every time you see this light. And it will tell us if you have visual damage from glaucoma, if it's progressing, if you've lost vision from a tumor or a stroke or an aneurysm. It's an extremely important test, and patients hate it. It's frustrating. These lights come fast and furious. You have to click the button. If you have any kind of arthritis, you can't click the button fast enough. There are overachievers like myself that will not look at the center light, and you look around because you don't want to miss anything, and then that creates a poor test. In the old days, it was like the Wizard of Oz. Beware the man behind the curtain. And so there was no automated test. There was a person with a light wand standing behind a dark curtain who would turn the light on and off, and he would turn the wand back and forth, and you had to plot manually where the patient saw things. It was called a Goldman visual field. It took half an hour per eye. And if you had a good tester, it gave you reliable results. But you had to have a good tester. You had to have a good patient. And it was an hour.
Oh.
Went to an automated field, which has gotten better and better and better. And so the test is about 3 minutes an eye. There are some people who just can't do the test. They get so freaked out that they get unreliable results. And I'm always saying, calm down, relax, I'm not grading you. And I will tell patients sometimes, you're a terrible test taker. You're a nice person, but you're a terrible test taker. And they're, well, why? Why? Teach me. The people who do the best are people who don't need it. If you take a 10-year-old and you put them in the visual field machine and you say, if you get all the lights right without looking around, you get a lollipop, they make the best test that's perfect with no fixation losses, meaning looking around. They don't miss the button at all. But people our age who are listening to our show, we don't like this test.
Yeah. Yeah, even now in the beginning of shows that you watch on whatever TV, it'll say beware of flashing lights or whatever, because some people, too, are very sensitive to flashing lights. So I don't know if that has any play if you're...
So if you had a seizure disorder, we probably wouldn't do a visual field test. People often say, oh, well, I had flashing lights like that before. Without this test, no, that's your retina. That's not that you're just imagining you're taking the test.
Well, are there any other tests, Dr. Mittleman?
So we do a lot of low-tech testing. These are all high-tech on machines that are very expensive, that take very skilled technicians to run them. But we have low-tech tests like a Hertel exophthalmometer.
Say that fast 3 times.
So it takes a while to say that. There are all different kinds of words in ophthalmology that I love saying, but I actually have to stop and think and say, my tongue, do this, do that, because they are tongue twisters. But a Hertel exophthalmometer will measure whether your eyes are bulging or whether they're actually sinking in. So there are all different diseases that can cause this. For instance, thyroid disease can make your eyes protrude. Bulge is probably politically incorrect these days, but protrude, and they can protrude unequally. You can have trauma. You can fall off your bicycle and break one of the bones that surrounds the eye. The eyeball is very well protected by the bones, by the eyeball socket called the orbit, but if one of them breaks, your eye sinks in, which can cause double vision requiring repair. And this very low-tech test, it's a machine, it's an instrument with mirrors on it, much like a sextant in the old days of seafaring, and you put it up to the patient's head, you close one of your own eyes, and you look and see where the lines line up, and you write down the little answer, and they should be equal, and there's a norm range. But you can do it again in 6 weeks after trauma and see if the eye is changing and so forth. Or you can measure double vision. Not double, you measure protrusion, which might cause double vision in somebody with thyroid disease. Color plates. I have a very good friend who lost her color vision in one eye. And so people are born with color deficits, color blindness. There are all different kinds. You might have trouble seeing red or green. But you can actually acquire color vision. And there are lots of different diseases that will cause it. We have color plates. They're called Ishihara color plates after a gentleman from Japan who designed these plates, and they're numbers made out of dots of different colors. It's very quick. You have the patient read 12, 17, 42, 9, 3. But when a patient can only read the control number of 12, you say, oh, there's some color loss here. And then you have to worry, is that an optic neuropathy or a problem with the optic nerve? Is there something pressing on the nerve? Glaucoma in its end stages, but only the end stages will make you lose color vision. There are many different things. And it's a simple test. You can actually have loss of color vision in both eyes, but it can be relative. And so we do a red desaturation test. And we take an eye drop bottle with a red top. We say, cover one eye on a scale of 1 to 10, how red is it? Cover the other eye on a scale of 1 to 10, how red is it? And if they're different colors, that's called red desaturation. Simple test. But it can tell us so much about how the eye is working.
Well, I can't imagine there are any more tests, Dr. Mittleman. But alas, there must be.
Oh, there are so many more tests, and I need to know them all. And we do some of them sometimes, but these are the more common tests that patients will encounter in a standard eye exam, or if they have just sort of run-of-the-mill problems. So no problem for a patient is run-of-the-mill, but what we call bread and butter ophthalmology. It's what you see. The other tests, we have ultrasound tests, we have tests for measuring for cataracts, all different ways of measuring the curvature of the eye.
Well, we have learned so much this morning, Dr. Mittleman, and who knows what next week's Through the Eyes of Dr. Mittleman will entail. You never know. But this was fascinating, and I think for us as patients, we're going to be a little more, at least I am, patient to do the tests that are prescribed when we go to Mittleman Eye. I mean, this is for our own good.
So just a quick reminder to all patients and all people, if the doctor or technician is doing something and you don't know why or you don't understand, just ask. And if they won't tell you what they're doing or why they're doing it, find another doctor.
There it is. Thank you so much for being with us this morning, you listeners, and thank you, Dr. Mittleman, always for your just wealth of information and fun.
My pleasure, and great ocular health to everybody out there.
Thank you for listening to Through the Eyes of Dr. Mittleman here on Legends Radio. You can tune in every Saturday morning at 8 a.m. for another edition, brought to you by Mittleman Eye, 561-500-2020 or mittlemaneye.com.